It's now recording. Okay, so very quickly, Sohail, you'll be leading this session. Thanks for arranging. Anyone who wants to ask a question, please either put down in the chat box or virtually put your hand up, and then we'll come to you. But the panelists, if you have any burning questions during the case, then as Sohail mentioned, you can interrupt any time. So over to you, Sohail.
Okay, so thank you very much to all who've joined us this evening. I'm going to just share my slides with you, just a few pointers about what we'll be discussing today. So this is the second of the PCI case discussion sessions, and I hope you can all see my slides. Let me just maximize those. There we go. So so, you know, when we've put this together, really it's for the audience and the participants to take part. And actually it's your meeting, and we have to discuss what's important to us as interventionists and what's important to our patients as well. So a big thank you to my co-chairs. I wouldn't be able to do this without them. So Javed Iqbal is joining us from Sheffield. We've got Saqib Ghani, who's looking after the IT side of things. And we've got Dr. Tariq Azim from Derby. So I'm very grateful for their participation. But actually, it's also our presenters, because without the presenters taking part, this meeting would not be possible. So when we put out the call for cases, a flood of cases came in. And I thought actually for this session, we would run it on a theme. And in fact, we've got a set of cases on left mainstem that came in. Now, of course, this is the most important segment of artery. It is usually around 3 to 6 centimeters in diameter. It's 10 to 15 centimeters in length. And when the left mainstem is affected with atherosclerotic disease, it usually affects the bifurcation area. And what we've learned from intracoronary imaging and also, unfortunately, pathology, is that when this atherosclerosis is present, it extends out into both of the branches. It usually tends to spare, interestingly, the bifurcation angle. And this is probably because of the high shear stress that is present here. So the cases that we're going to discuss today are all going to be left mainstem, but actually these are varied left mainstems. And of course, when we're tackling left mainstems as interventionists, there are a few important questions, and I'm hoping that my co-chairs will bring these into the discussion as we go along. The first question, of course, is, should we be doing left mainstem PCI at all? I think it's an important skill set that interventionists need to have, because occasionally you will be caught out with a left mainstem primary PCI. And of course, those cases will need to be dealt with proficiently and efficiently. The other major questions are, should elective left mainstems be discussed in an MDT? Or in fact, should we take these cases on as ad hoc PCIs, cath query proceed cases? When we do left main PCI, is it important in terms of volume? So, you know, is there any data to suggest that those who do more left main PCI cases, are they better operators for those patients in terms of morbidity and mortality reduction? Or is this a skill that actually all interventionists should be taking on? And of course, the big question which always comes up is when you're tackling these, should it be 1 stent technique or 2 stent technique? And if you're going to do a 2 stent technique, which of the 2 stent techniques are we going to employ in these cases? Intracoronary imaging, I'm sure that will be a big discussion point. Should it be done? Should it be IVUS? Should it be OCT? Should it be made mandatory in left main PCI? And of course, support devices. Do we need them in these cases, or can we get away without using support devices? So these are some of the discussion points which hopefully will be brought out as we discuss the cases. So I'm going to hand over for the first case to Jawad. Jawad Iqbal is going to moderate the first case. So the first case is coming to us from, in fact, all of the cases today are coming from the West Midlands. So I work in the West Midlands, and it's good to see that the registrars have put together some fantastic cases. So Jawad is going to present the first case, and Javed Iqbal is going to be the main moderator on this case. So Jawad, well, why don't you go ahead, unmute yourself, and present your case. Thank you. By the way, I just want to add, if there are any questions, please just put those into the chat box. We've got Saqib on the IT side of things, so he'll pick up the questions. And if you want to put your hand up at any stage, we'll try and make this as interactive as possible, because it's meant to be a learning experience for all of us.
Hello, hi. Can everyone hear me?
Yes, we can.
Yeah, that's fine. My name is Jawad. I'm just going to start sharing my slides for my case. Give me a second. Can everyone see it?
Yep, it's fine.
Right, so I'll be presenting the first of the left main stem PCI case series this week. My full name is Muhammad Jawad Al-Qamar. I'm one of the ST7 International Cardiology in West Midland, and I did this case just 2 months ago with Dr. Suhail Khan in Queen Elizabeth Hospital, Birmingham. So the background, this is about a 61 years old lady who was alerted to us through a primary PCI call by the West Midlands paramedics with a severe ongoing retrosternal 10 out of 10 pain. It was radiating to the arm and the neck. She was reportedly very clammy, sweaty, and nauseous. She was given sublingual GTN and IV morphine by the paramedics, and they said that her blood pressure is about 85 systolic. Just to set things up, although at that time we did not have that history, but she is known to have a TAVI valve implanted in 2017, which specifically is a 25 millimeters neo-accurate valve. And she was a surgical turn down because she had some comorbidities, least of which were the PCI to RCA, that she was known to have ischemic heart disease, bronchiectasis, but most importantly, she was CKD stage 5 on hemodialysis, and she was having dialysis sessions at least 3 times a week. She was slightly overweight as well, and these were the reasons why she wasn't considered a candidate for the TAVI valve, for the surgical aortic valve replacement for aortic stenosis, and she was offered TAVI valve instead. So this was the ECG that was sent across to us by the paramedics. I'm just going to be quiet, and I'm going to ask all of you to have a look at the ECG for a few seconds.
Jawad, give me a prompt and I'll put up your questions.
Yeah. Now, 3 months ago, she presented to AMU with symptoms suggestive of unstable angina. At that time, her troponin was 46. And that was, if you remember, in the context of chronic renal failure. And this was the ECG then. And that was just 3 months ago. At that time, a different interventional colleague took her to cath lab for diagnostic coronary angiography and reported it as a mild mid-left main stem stenosis with minor atheroma elsewhere. Now going back to the ECG this time, and Saqib bhai, if you could just put the questions.
Can you all see it now? The poll is there. We've got half the answers back. We're going to wait till all of them, or at least most of them, respond.
Jawad, while people are answering the question, you showed the previous ECG. You have the angiogram, previous angiogram 3 months ago?
No, I don't have access to that angiogram from 3 months ago. but you will see the pictures very soon, and you will see that the angiographic pictures more or less look the same.
Okay, we only got. I assume the panelists have not voted, and maybe these are the people pending. So that's fine. I'll just gonna share the results of what I've seen so far. This is what people have responded. Jawad and Sohail.
That's quite interesting. So me and Dr. Khan also felt that in the presence of a new left bundle branch block, for a patient who is hemodynamically unstable with a severe central crushing chest pain and more or less ST elevation in the AVR in the context of left bundle branch block with quite deep ST depressions in the inferior lateral leads, this could be an ongoing left main stem stenosis leading to severe ischemia. Now, we activated the primary pathway, PCI pathway, took it to the cath lab straight away. We punctured the right femoral artery using ultrasound guided micropuncture kit, used a 6 French femoral sheath, and then used a 6 French AL1 guide to the right coronary artery and a Voda left 3.5 6 French guide for the left coronary artery. So these are the pictures for the right coronary artery. Can everyone see the cine runs?
Yes.
Here, I would also like to point out for budding interventionists, the first picture, which is the LAO, the AL guide is not pointing in the same direction as you would expect to engage the right coronary artery. And this is something that we may have to see more and more as patients with TAVI valves come for angiographies and primary PCIs, that sometimes you have to engage the coronary arteries in very exotic, different sort of ways. Sometimes you have to innovate ways in which to intubate these coronary arteries because they are not going to be straightforward. So this is one way where the right coronary artery was opacified just enough to see that there is no significant occlusion in the right coronary artery. And
may I ask why the femoral route was preferred than the radial route?
so as I mentioned, the patient was a CKD stage 5 and hemodialysis dependent.
Right.
She already had an AV fistula on the left arm. And because the blood pressure was quite low, her right radial pulse was also quite weak. Considering that she had low blood pressure and we felt that she may have cardiogenic shock, in order to preempt any insertion of intra-aortic balloon pump later on, we felt that it would be easier and safer if we go for the femoral approach.
Yeah, I think it's interesting. If there is a TAVI valve, the femoral route is actually a preferred route. It's easier to engage into the left coronary. I did a couple of cases. Last case I did was about a month ago, and I was actually told by Dr. Kovac, they do a lot of these cases, that if you have a TAVI valve, do the angiogram via the femoral route, and you'll be able to engage the coronaries better. Thank you.
Dr. Tariq, whilst, or the speaker, whilst you're there, I know the case is going to go ahead. To keep it more interactive, if I can just ask a question now for the audience about elective left main. I just want to see how they would prefer to approach stable left main disease. Then we'll come back to this case. While we're on the topic, I thought I'll just bring it up.
Yeah.
So this question is about elective left main, not emergency, because emergency, you don't know what you're dealing with.
So this is not particularly about this case, is it? Any case?
No, any in general. What would the audience, what would be your choice of vascular access in stable left main case disease? So we got almost 80% answers, and actually it's a nice mix. I'm gonna end and share just to generate some interest. So 70% would like to go radial, but 7 French. Okay, interesting. You can all see what's on the screen?
Yes.
Okay.
it's quite interesting, actually. 7 French radial, although it's better to have 7 French, but it may not be always possible.
Yeah. Anyway,
I think
comments?
what it shows that the people are happy to do it radial, which I think is reasonable in a stable elective patient. The choice of 6 French, 7 French obviously will depend on what you think upfront in terms of what's required in the left main, and also what size you think you can get it. Because these information were not given, and it was more of a choice thing that what would you prefer to have it. So I think 7 French radial as a choice is a good one.
Okay, carry on, please. Carry on with the case. Sorry to interrupt.
That's fine. These are the first 2 pictures that we took, the PA caudal and the RIO caudal. All of you will probably appreciate that it's self-selectively engaged in the left main. The catheter tip is just there. And soon after this, there is a bit of stenosis that our interventional colleague 3 months ago would have noticed then and marked it as a mild mid-left main stem disease. This then joins a big confluence of the left anterior descending and the circumflex. And the circumflex ostium is quite funnel-shaped, but overall, the circumflex, I can't see any significant narrowings that would explain the symptoms. The next pictures will be for the spider and the eleocranial. Now this is quite interesting, and I will just stay quiet so that you can appreciate the left main stem appearance in the spider view, as well as the eleocranial.
It's quite interesting. I think
so before you ask your question, Jawad,
yeah,
first you tell me that yes, we can go to this decision point in a moment, but this patient is in cardiogenic shock.
More or less, yes.
More or less.
Yes.
And whether left main is significant or not, we can come back to it. But there is TIMI3 flow in all the vessels.
Yes.
So why do you think? Is it just ischemia driven? Or at that stage, whether you would think about, because patient had a valve, is the valve working okay? Do we know anything about valve leak or anything? That's one thing. Or whether you think it's all ischemia driven, because it's not an occlusion. We are not talking about that a vessel is completely occluded and patient is unwell because of that. Yes. You may say that whether it's ischemia driven if left main is significant, or could there be any other cause at that time? What were you thinking?
So although we did not have any upfront echo for this patient because the patient landed straight on the cath lab table, but looking at the history suggestive of sudden onset chest pain, which in the context of someone who's known to have mild left main stem disease from 3 months ago, and also quite a changed ECG. So if you compare the ECGs from 3 months ago to the one that we had just now, the patient had new left bundle branch block, ST elevation in the ABR, and ST depressions in most of the leads. So we just felt that we have to investigate the coronary system properly before we think that this could be a problem with the valve. Plus the patient is there on the cath lab table anyway, so why not investigate her for the first problem at hand and then move on and exclude the second problem.
It doesn't look like, we can't see any significant obstruction to left main stem in both. In the eleocranial view, there is an angle just before the bifurcation, and in eleocaudal view, again, there might be a bit of haziness just before the bifurcation, but we can't see any stenosis.
Yes.
I think that's interesting and very important comment by Tariq Bhai, because here, if you're not seeing an obstruction, if there is a lesion and you think that the patient has been very unwell and is still unwell, what you must be thinking that there is not just a plaque, there was a plaque, whether that plaque was unstable and had some thrombus on it, which by this time probably is not very evident. So you are looking at possibly an unstable kind of plaque.
Yes, yes. So
Yeah,
there
I
are many
mean,
possibilities here. Now, I don't want to give away a couple of pointers here because there's a question coming.
Yep. I'll come to the
So,
question. Before we come to your poll question, there's a question in the chat box from Lal Mughal that what was the invasive blood pressure rather than the actual initial A&E blood pressure?
So
And
throughout the case, from as soon as we got the first catheter in, the blood pressure was never more than 90 systolic.
was the
So
lactate high?
yeah, so it was ranging between 80 to 90 systolic. And the patient was quite nauseous and she was twisting and turning. So she was in pain.
Okay. Coming to your poll question then. I'll launch this question. There you go. So whilst we've taken these pictures, what should we do next?
I'm going to answer this as well because I think my view might be slightly different.
And whilst people are answering, there are other two comments in the chat box. One is, if the patient was in cardiogenic shock, did we still need to do the right coronary artery short, or we should have gone straight for left main? That's one question.
So first of all, in the case of a primary PCI, it's you can never be sure which artery is the culprit. Sometimes, in fact, everyone might have seen these patients in which the left system is occluded and the patient is surviving from collaterals from the right coronary artery. And in this patient, in these sort of patients, you would go in thinking that it's the left main stem disease, but then the LAD is already occluded from before, and it's the right coronary artery which has led to cardiogenic shock. So having a look at a contralateral artery is always a good idea. And while training for the last 5 or 6 years and seeing different approaches, I'm actually incorporating this, looking at non-culprit artery look first before we go ahead and look at the culprit artery. It gives you so much information, to be honest.
And one other quick question is, was there any pressure damping when you engaged?
You have just stolen my moment of glory. So
okay, we'll hold fire. Okay.
So this would actually give away the next choice of
May I just
investigation.
ask one question? Sorry to interrupt. I think angiographically it looks like that there is TIMI grade 3 flow. We can't really see the stenosis, and there can be other explanations for ECG changes as well, because it's aortic valve disease and there's a progression of connection tissue disease in many people with aortic valve disease. So apart from chest pain, and patient is clinically looking like that there may be something going on, angiographically we haven't seen anything remarkable.
That's very good. So you mentioned angiographically. Now obviously angiography is a combination of fluoroscopy as well as hemodynamics, and the information that I deliberately withheld initially was, as soon as we engaged the guide, the pressure plunged from 90 systolic to 50 systolic on the invasive monitor. So we had to withdraw the guide and then float 2 run-through wires into the LAD and the circumflex, and then backed out the guide, which recovered the pressure. So that actually gave us a clue that even though we are not seeing very severe or moderate lesion in the left main, there must be something going on which is causing that significant pressure drop.
Jawad, was there, let's just rephrase this question, was there only pressure drop or was there pressure damping? These could be two different things here. Yeah. Because the pressure drop, whatever was causing the original problem, can cause it. If when you are using EBU in these patients, sometime because it's going to the aortic root and then coming up to it, then you can keep the valve open, and patient can get sometime an acute AR on the background of their other problem, and then their pressure can actually further drop. Was there any pressure damping?
So it was the pressure actually, I think drop is actually a misleading word. It's actually more of pressure damping on deeply engaging the left main. And if the catheter was just at the ostium of the left main, the pressure was fine. But even a couple of millimeters deeper into the ostium, the pressure became really damp. So you would actually see the change in the trace, and the systolic at that time was recorded at 50. which would mean that there is something which is obstructing the tip of the guide.
Mhm. Yeah, I think let's proceed but I agree with what Tariq and other people are saying, that at this stage, patient is in shock and there is a TIMI3 flow with possibly a lesion in it. You should keep other options in your mind.
Absolutely right.
Definitely.
Yeah.
Okay, in the interest of time, carry on with the case now.
So we went ahead and did an IVUS study of the left main.
Okay, just to interrupt you for 1 minute, because I said that I'm going to participate in the last poll, and the reason for that was that because I said OCT instead of IVUS. The normal accepted thing is that for left main you need IVUS. Here the lesion is not in the ostium, it's in the body of the left main. And also your question is in one way, is that an unstable plaque in the left main body? And my personal feeling is that yes, you can get enough clearance of the contrast and the blood, enough clearance of the blood in the left main body to get exact idea of yes, there is a plaque and there is an unstable plaque and possibly a thrombus there, which will give you much more reassurance rather than just seeing a stenosis in the left main. Because yes, we know that there is some stenosis. Is it hemodynamically significant or not? That's another question. But if I see a ruptured plaque with some thrombus on it, and then I will know, yes, that's what was the culprit of this patient's presentation. So that's my reason for OCT.
Yeah, I agree.
So actually, can I come in there? So Javed, what will, if you're going to do OCT, what will be the depth available on your OCT machine? Because
you can go,
one of my concerns here was this is a absolutely huge left main stem.
Yeah.
And you may not be able to see what you need to see as far as the vessel is concerned.
I mean, if you change the field of view, you can get up to 10 millimeter.
Okay. So that's an important point, isn't it?
Right. So I'm just going to start the first IVUS run, and I'm going to let you all have a look and appreciate the IVUS pictures, and then I'm going to do a little commentary.
So this is run from which vessel?
So this is an IVUS. I just showed you in the last image that the IVUS probe is mounted on the LED wire, and it is coming from the ostium or the proximal LED back into the left main. And bear in mind that we have already wired the circumflex, so you may be actually seeing the circumflex wire coming from 7 o'clock and joining the LED wire at around 3 or 4 o'clock. And bear in mind that the circumflex ostium was quite huge. And as we came towards the left main, it became a bit. And I'm going to play another IVUS run from the same time. So this is starting again from the distal left main, and you can see that as it comes towards the mid of the left main, and I'll just pause it, bring it back and pause it. Over there, it looks very tight, and it appears there's suggestion of a possible calcific nodule at 11 o'clock. But at the same time, when we did the minimal luminal area measurements, the MLA at the tightest point was 5.1 millimeters square.
We can't see all the circumference where it's the tight, basically. So how did you measure the area?
I'm just going to run again.
Yeah, there it looks like there was one frame.
It was that one frame.
Yeah, this one, I think.
Yes, exactly that one. I was just trying to pause it, but for some reason my computer is not allowing me to do it.
But it can be an angle as well. You know that there was an angle in the left main, and it can be quite difficult to image with the IVUS. And although there is some suspicion in some frames that there is a lesion which may be significant.
So
There we
this
go.
is another poll.
Let's see what other people think. Yeah. Just to let those know who've not used this before, if the poll is obscuring your screen, you can, with your own cursor, move it around so that you can still see the main screen. This one is taking time. I think only 65% received. Feels like Biden and Trump race, you know. Go on, guys. Whoever is left, it's anonymous. Give it a shot. There's 1 in 3 chance of getting it right. I'm going to stop the poll in 5 seconds. 3, 2, 1. There we go. 60% think it's a severe middle left main stem stenosis. 30% think it's ectatic left main calcification. Some think it's a TAVI strut. Interesting results, Jawad bhai.
Yeah.
Yes.
And Jawad and Javed, yeah.
The
Yeah.
one thing that is that this valve has been implanted 3 years ago. And what we are seeing is we are seeing it in the body of left main, not necessarily in the ostium. So, I mean, the chances of that causing any problem in the shaft of left main is pretty low. So I will probably exclude the option 3. The other 2 options are interesting, although I think if I give an option of 4th option of others, probably Dr. Tariq will go for another one, saying that it is none of those.
No, I won't say that. But I think there is disease, there is a plaque. Whether we have yes, he's showing the frame, although we can't see the whole circumference. There is disease, whether it's critical or not. It's difficult to say. Based on we should have very good frame where you can see the whole circumference and then you can measure the diameter.
So yeah, at that time, because the patient's blood pressure was low, she was having chest pain. But in the circumstances, this was the only obvious problem, which was a significant stenosis in the mid left main with a minimal luminal area of 5.1 millimeters square.
Yeah.
So
do you think that is sufficient to put anyone in cardiogenic shock?
I think if someone has been, it could be that the patient has been having dynamic obstruction. There could be a possibility of a little thrombus there that we never saw with IVUS. And by the time that the IVUS probe went there, the thrombus disappeared. Or with the contrast flow, we couldn't see the thrombus anymore. But certainly, a 5 millimeter square narrowing is enough to give patients unstable angina. Although it wasn't an occluded left main, but it could have been almost occluded or critical because of thrombus a few hours ago or a few minutes ago.
One question that's come up twice now is, was this diagnosis of shock complemented by arterial blood gas and lactate levels?
So at this very time, we hadn't done the gas yet, but as is the case with most of the STEMIs, we usually do a blood gas at the end of the case when the nerves are a bit more settled. So at that time, we didn't have the pH or rest of the things. We were just getting on with the case.
Okay,
all right, so
let's carry on. Yeah.
I'm just going to move on. Now, I'm sure that most of you would have seen that the distal and the proximal left main was huge. And when I say huge, the diameter of the distal left main in some frames was as high as 10 to 11 millimeters with a MLA of more than 20 millimeters square. As all of you know, that there is no balloon that's big enough to actually stretch an artery to that size. because we had two wires anyway, one in the LED and one in the circ, we mounted two side-by-side 4.5 millimeter NC balloons and performed simultaneous inflations on both the balloons to give an expected size of about 8 to 9 millimeters in the left main. So this is just a little frame which shows that expansion. And in the next,
Jawad.
yes.
So with two 4.5 millimeter balloons, what area you are expecting to achieve?
We are expecting to achieve an area of around 19 to 20 millimeters square MLA, which was the area of the normal left main. In the
And what stent would you put in that area then next?
So the option wasn't to actually get the calcific nodule or calcification or the stenosis all the way into the wall, but to just push it enough so that we have an MLA which is of a slightly higher size of what it was then.
No, my question is that there won't be any stent available in coronary lab shelf that
yes.
will be big enough for you to cover this if you are thinking 8-9.
I completely agree. So the biggest stents that we have, as you know, is about 5 millimeters coronary stents. We discussed about this yesterday. We could actually do a side-by-side two stents in the left main, but we also then discussed that this is not something that we would routinely do. But the idea
can
was,
I chip in here? Sorry.
Yes.
Sorry to interrupt. I think the bifurcation of left main is ectatic. Sometimes because there is atheroma in the mid left main stem, and you do get post-stenotic dilatation. That's not actually the original diameter of the left main. Left main was much smaller than that, but because of the fluid dynamics and because of the aortic stenosis, bit of disease in the left main stem, bifurcation has become ectatic. I would never actually make the PCA result or to achieve, accept that ectatic segment is the normal diameter of the artery, because like Javed has pointed it out, you will not get a stent as big as that. What I would think in this sort of case is the ostium of the left main, or you see maybe proximal LAD just after post-stenotic dilatation, and the left main will be roughly similar or slightly bigger than that, rather than measuring the size of left main in the post-stenotic dilatation segment.
Yes, I completely accept. I think the whole idea of this pre-dilatation here was not to make the artery as big as the ectatic left main, but it was actually to prepare the calcific segment enough so that the stent doesn't get crumpled or misshapen once it's deployed. So we just wanted to make some space for the stent.
But what was the reference diameter in your mind that I'm going to, this should be the left main stem diameter if there was no post-stenotic dilatation?
So I would still, I don't have that still picture from the proximal left main, but even the proximal left main, which is not ectatic, the reference diameter of the proximal left main was 9 millimeter plus.
Yeah, at the ostium, I accept that it will be quite big, but fair enough. Okay, let's see how we go.
So this is just, we're trying to position the stent. And deploying it. Bear in mind, it's a 5 by 15 millimeters onyx. And then this was post-dilated with a single 6 by 12 millimeter NC balloon.
So which view was it? Was it alveocaudal when you were positioning the stent and deploying it, or which view?
Yes. So we are actually, I think we are deploying the stent in alveocaudal view, yes, spider. Yeah.
Right.
No, I think that was the aleocranial view.
Right.
Yes,
that looks like aleocranial.
But actually,
aleocranial,
yes, this lady's got a very rotated heart, so it wasn't quite working out. So.
Yeah, I mean, aleocranial is generally very good view to see where you need to deploy. But here you have got another hard landmark as well, that where the aortic wall is. Yes, the valve is in the aorta.
Yes.
But there is sometimes, Javed bhai, there is sometimes distance between the TAVI valve and the aorta, so we can get misled.
Yeah,
because
that's a very important thing, because knowing exactly what valve is this one, that will help, because the valve shapes, the shapes of these skirts and things are different for different valves.
So this is a self-expanding neo-accurate valve. And for those of you who don't know, you would sometimes use a self-expanding valve in somebody who has LV outflow tract calcification, because if you do put in a balloon expandable valve, there's a risk of causing aortic root dissection and rupture. So of course, this is information that we found out subsequently, but we didn't have that information at hand at the time. But it was fairly easy for us to determine what type of valve it was. It's a supraannular neo-accurate valve.
I mean, in terms of this self-expanding one, I think, I mean, you guys did a great job, but still it's good that it was accurate rather than core valve. I think engaging and doing procedure through the core valve is even more challenging.
Well, actually, you know, coming back to the point that was made earlier, the reason I actually went up with an Amplatz guide was that I was hoping to fit it into the left coronary system rather than a Voda left, which is what we eventually used. But as it happened, it sat very nicely in the right coronary artery, allowed me to take a picture of the right, but I could not fit the Amplatz guide into the left, which is why I then switched out to the Voda left.
You know, JL 3.0 or JL 3.5, those are, you know, sometimes they're the best catheters to actually go through. I have a case, I mean, if you allow me.
I guess the question is, you know, are you talking about access to the vessel, or are you talking about subsequent support as well? Because, you know, Judkin's guides are great for getting access to the vessel, but I have to say I found that unless you're 7 French, support further on down the line is a little bit tricky.
You're absolutely right. I think they won't give you the support. And however, what you know, most important is getting to the coronary, and for that the Judkin catheter is much better for the, especially through the TAVI valves. What I normally do is put the guide catheter extension, especially if it's not a, you know, bifurcation, so you can actually engage it, wire it, and have a guide catheter extension like guide liner, and it gives you fantastic sort of access to the artery without any having interaction with the TAVI valve struts. And you can do quite neat and clean job very quickly. But with this, obviously, you've done a wonderful job here in this case, I must say, because these long nose catheters, they're not easy to engage into the coronaries through the TAVI valve struts. But Judkins, for diagnostic, you always use Judkin, and you will be able to get through.
I'll just
go ahead, Jawad.
He then post-dilated the stent with a 6x12 NC, and then stretched up the ostium of the stent of the left main as well. And then we repeated the IVUS, and I'm just going to play the run. This is again starting from, has it stuck? From proximal LAD, and it will come back to the left main.
So coming back to Dagpay, your point about the size of the left main, you're absolutely right. There's post-stenotic dilatation here. And actually one of the accurate ways to assess the size of the left main is to look at the native circumflex and LAD, and sort of work back using Murray's law to work out what the size of the left main should be. And as you mentioned, that, you know, there's no stent that is going to be able to expand much more than 6 millimeters. Certainly no coronary stent. Biliary stents is a different matter.
I think since the circumflex and LAD ostia, they were normal. And I think having a short stent in the left main, starting from the ostium of the left main to finishing just before bifurcation would have been quite reasonable. Again, I don't know what did you use, and you might appear that you have got very good result already.
So I'm just going to go back to exactly where the stent started. This is sort of distal left main, and now we can see some struts of the stent coming through, although we can see some under expansion in the distal bit, but as Dr. Azim pointed out that was the ectatic bit anyway, so no stent would actually go and stretch up to that level, but actually we can see good stent apposition whenever the frames come through. The stent is well opposed.
Yeah, I don't think we'll ever be able to oppose the stent in the stenotic segment because it's so big. But I don't think it would matter if it's not that well exposed in the stenotic segment. It will get endothelialized. Most important is STEMI grade 3 flow and having dealing with the stenotic segment. And the rest, even the post-stenotic segments, they can regress when the flow is normal.
Yeah, and then we did another MLA of the segment which was previously 5.1, and it came back as 19.5 with a diameter in the long axis of about 6.8 and the short axis at 2.8. You can see that it's a bit of an oblong sort of a left main, but that's purely because that was the best diameter that we could get with the size of stent and the type of NC that we had at that time. And
what was the stent type you used? Sorry.
That was a 5 by 12 millimeters onyx.
Onyx. Yeah, that's very good.
Yeah, somebody in the chat box has Usman Khan puts Synergy Megatron. That's also not a bad choice if you have it on your shelf.
Yes, I've come across that brand. They are supposedly quite tough for left main. So, but unfortunately, I don't know whether Dr. Khan can correct me. We didn't have it on our shelf that night.
We don't have the Megatron. So, I mean, the important thing is actually to know the stents that you have on your shelf. And what we have in our cath lab is a chart that tells us what the stents will expand to. The last thing you want is to put a stent in which isn't going to expand up to 6 millimeters. That would be an absolute disaster. The other thing to say is so that, the IVA studies haven't shown any downside to leaving malopose stent struts. This is not associated with stent thrombosis. So, we always worry and concern ourselves with trying to expand the stent as much as possible so it's opposed to the vessel wall, but there isn't any strong data to show that increases your risk of stent thrombosis. And there was clearly no way I was going to be able to oppose the stent in this ginormous left main stem.
So, one question has come up. Would it be advisable in these cases to have anesthetist on standby, and how to support blood pressure during the case?
Oh no, absolutely. I mean, if you have a shocked patient, and if there's a concern, then alert your anesthetist early on in the case. There's nothing worse than that, having your anesthetist come down, whilst you're performing CPR on your patient. So, always give a heads up to your anesthetic team and let them know that you have a sick patient who's there. Here, fortunately, as soon as we backed out the guiding catheter, then this is an important point, actually, that the pressure would recover. So, the important learning points here is that don't always believe your eyes. Your eyes are good, but the IVUS is even better.
So whilst we're on that, two questions have popped up, which are actually in our poll. So I'll just bring it up now, which is, I think, the right time for this question, that in most of the left main cases, would you consider LV support before intervening or during?
Yeah, I think the other thing which I would like to mention is when the blood pressure is going extremely low, like in cardiogenic shock, intra-aortic phenylephrine, we do quite often in shock patients to buy a time window to complete the case. So I usually give 100 to 250 microgram intra-aortic bolus of phenylephrine. It brings the blood pressure quite significantly up, and you get few minutes where you have a good blood pressure and you can complete the procedure or get the flow in the coronary at least.
Anyway, this is the poll result as to what the audience feels. Sohail, would you agree with that?
I clicked not needed actually, so
So did I.
So the point, I guess, we have some data from the IABP shock trials, and you know, IABP now is a class 3 indication.
Yes, it
Yeah.
can be even dangerous. Yes,
yeah,
according to the.
so actually, I have given up using IABP, but then we're fortunate enough to have the Impala available in our cath labs and on our shelves, which I appreciate not everybody has.
But in this
Impella in a
particular
TAVI
patient,
case, yeah.
Impella in a TAVI case, we have used those before, and in fact we've deployed Impellas in patients with critical severe aortic stenosis, and you'd be amazed that the Impella just drops across the stenosed valve. Occasionally you have to do a balloon angioplasty of the valve up front, but actually many of the times it will just go across the valve. We've written up our experience of that. Yeah, so it was going to be in my hands. This is either a smash and grab PCI or it's an Impella guided PCI. But the important thing here to note is that every time I back out the guide, the blood pressure would recover. So I was quite happy that I'd be able to do this case. And having 2 wires down allows you to back out your guide, and means that you can do the case with reasonable blood pressure.
Data
I think
for Impella?
Jawad, this is your last slide. I think
And then
patient has done well.
people may have read it, but then just conclusions. Increasing number of patients with TAVI. Now the PCI in such cases will not be uncommon for upcoming trainees. For completing diagnostic angiography with ostial left main disease, it may be useful to wire the vessel so that we can control the guide, just like we did, because as Dr. Khan mentioned, as the guide dived in, the pressure would drop, and having a wire inside the artery would allow that extra bit of control on the guide without actually it popping out completely. And then if clinical ECG appearance is of STEMI or ACS and coronary angiography is not conclusive, then any form of intracoronary imaging is of real help, including IVUS and OCT. And with that, I would thank everyone for bearing with me for my presentation. Thank you.
Brilliant, Jawad. If you can stop sharing the slides. Brilliant. Sohail, if you agree, shall we quickly move to second case? Because
Yes, no, we're already over time actually.
Exactly.
So I think we should quickly move
Shoaib
to the
Qayyum
second
is our second speaker. Shoaib, can you unmute yourself?
Yeah.
And if you can share your slides, we'll try and keep the next 2 slightly shorter, but then obviously when the appropriate questions come up, we'll have to discuss.
I think the fact that there's a lot of discussion means
That's
there's
good.
a lot of interest.
Yeah,
so
that's
I think
good.
that should be encouraged. Go ahead, Shoaib, if you just unmute yourself and put your slides up.
I'm just going to screen my, I will run it on my mobile.
So whilst we're waiting for that to come up, Jawed, what do you think? I was struggling with the IVUS to get good depth images. Would OCT have been able to image that distal left main stem?
So is that visible?
Probably not.
Yeah.
Probably
only
not.
one way. I think if you had a guide liner and use the OCT through the guide liner, then you could fill the image and clear the contrast. But with this left main, I think with having that sort of post-stenotic dilatation, it would have probably not helped, I think.
Yeah.
I mean, there was a Japanese study which looked at OCT versus IVUS for investigating left main stem lesions, and of course, 100% of the time, the IVUS gives you the information that you want, whereas only 95% of the time can you get the information with OCT.
Yeah. It
Right,
also
Dr.
depends on what information you're looking at. I mean, that's fine. But here the question, but 2 different questions. One is that is it stenotic and whether that's significant. The other one was, which I think still that yes, it was a lesion which was probably borderline significant, but it was unstable lesion. So OCT on the top of that will give you that yes, it's a ruptured plaque with some thrombus. But I agree with you. It would have been a bit of struggle here in this case.
Okay,
Yeah, I
panelists.
think
Sorry to
it's real
interject,
another
panelists.
thing
Panelists.
technically important about I was having, for example, if you had eagle eye, that is a 20 hertz probe, and it has the deeper penetration compared to this 40 hertz catheter I think you used.
Yes.
So
Okay.
You end up with a snowstorm though, and you can't make out anything.
Yeah,
That's why
Sohail, Tariq
argument
bhai
with
and
the eagle
Jawad bhai,
eye.
I'm gonna
Okay.
just let the speaker carry on if that's okay.
Yes, please do.
Yeah.
Go ahead, Shay.
Jawad, introduce yourself, please. Go back to your slide 1 and then carry on.
Okay. So I'm not Jawad, I'm Shoaib now.
Sorry, yeah.
I'm also West Midland intervention trainee. Presently, I'm working in Stoke. So this case wasn't made for this forum, but it's a good watch. So hopefully it will take shorter time because the slides are less. Can you guys see the screen? Because
Yes,
I
we
can't
can.
tell.
Yes,
Okay.
go ahead. Go ahead.
So this is a case that we did in 2018, and it's a case of a 72-year-old gentleman who was referred to Stoke from one of the district general hospital. He initially presented in December 2017 with an inferior STEMI and had a primary PCI done to his right coronary artery. At that time, he had sort of moderate LV impairment. And then when he was seen in his follow-up clinic, he was not entirely symptom-free. He was having a degree of shortness of breath and some chest tightness as well. And the clinician at that time felt that we need to further investigate the bystander disease. So about a year later, he sort of presented with worsening symptoms and was listed for an angiogram. His comorbid condition contained COPD, rheumatoid arthritis. He was hypertensive, but essentially well in himself, independent and self-caring. So initially, whenever we present, I think it's going to generate a lot of discussion. There is at least one fault on each slide. But anyway, medication-wise, he was on clopidogrel and atorvastatin bisoprolol 2.5 milligrams, and was not requiring any diuretics. So I started with the angiogram in normal manner from the right radial artery. So the right coronary angiogram was okay, which showed a patent stent in the proximal and mid LED. For the left side, because we were anticipating to pressure wire the LED, I took a EBU 3.5 guide.
Can you go back to the right picture? Go back a slide.
One second. I have to come off it to go back.
I think it looked like there was a lesion in the PDA.
That's what I was going to say.
There is a lesion in PDA. Yeah.
The right coronary artery, yes. Distal right. So
yeah,
because you'll have to come out every time. Yeah. So distal right, there is a lesion. Based on these two, I mean, this might be the one question for people. Would they go straight to PCI? Would they pressure wire as you were planning? Or would they just say, hold on, let's try tablets first?
While we are doing this question, I can ask one question, which is even before that. Before bringing this patient to cath lab with stable angina, he's only on bisoprolol 2.5. You might argue that should we try a bit harder with the anti-ischemic medication?
Yep.
Yeah, as I said, there is on each slide there is at least one fault, and on the first slide, most of the criticism was in that he's not on a optimized anti-anginal. He's about a year down from his symptoms, and whether it would be indicated to list him directly for a coronary angiogram.
So I have just one question.
So-
Was there any short of left coronary artery available from the previous procedure?
Yeah.
Yeah.
Obviously, he had
Is
an
there any-
angiogram. I haven't got it with me, but
Okay.
it looked similar to what you're seeing there.
Right, move on then. So,
Can-
in the interest of time, I think, so you said you're going to go with pressure via the LED, yeah?
Yeah. So,
Okay.
there you go.
So,
So, as you can see on the first playing, that the
don't play
guide
the
wasn't sitting properly.
don't play the second one yet. Yeah.
And four.
True.
And,
Can I ask you what's your engaging view for the left coronary?
It's LAO.
LAO.
Standard.
Okay.
Yeah.
So
Yeah.
But what's not there is that after the first shot that you saw in the last, the guide wasn't sitting properly. It was disengaging, and it took a little maneuvering to engage it again. And then on the next shot,
Yeah, go to the next
is
one.
the
then.
next one that's just still
Of
there.
course, it's wire radial, isn't it? The procedure.
Yeah, the procedure is wire radial.
Go back.
So did you think the
I don't-
guide was a bit short then? Is that what the problem was?
Yeah, the guide wasn't sitting in properly.
Okay. So,
like
what do you do normally then? You would persist with the same guide, or think about upsizing?
You
maybe?
could upsizing it. I think a 375 would have sat in more easily and more commonly. And then this was the next shot after it, which was complete dissection of the LED extending back into the aorta. So it was a aorta left main dissection extending into both the LED and left circumflex. You can see the horn. So it's
one question, sorry. Between this, the last shot, and when the next shot, when there is no flow, did you try to re-engage it?
no, this is somewhere in between. Yeah. So after the last one I showed you, I don't,
because this is not engaged.
Yeah.
This is
so
not
after that,
engaged,
it would have been re-engaged. Yeah.
Re-engaged. Okay.
Yeah. So the main point was that the guide wasn't sitting properly, and then that's the mistake on this side, and quite a dear mistake, I would say. So he had a type F left main stem dissection, which is usually incompatible with life. So when this happened, the next thing because this was an elective case, so we put on the pads on. We did call out cardiac arrest as well, and we got help from call for help from our senior colleagues who were luckily nearby, and also called the surgeons as well. So in this all chaos, another mistake, if you see on this side, so this is the next slide. So because for putting automated resuscitation equipment on, you have to lift up the patient. So we lost the guide position at that time to start the resuscitation. So in retrospect, people, usually operator would advise that you don't disengage, you at least put a wire, because the most chances of getting into the true lumen is if you don't move the guide or move it a little bit and try crossing it with the wire. But that's retrospect. So then what we did was trying in hope to get into to engage the ostium again. We changed to a Judkins guide so that it might flip into the ostium or even get near to the left main ostium. So we used the Judkin 4 guide and then started off with conventional workhorse wire with a sign blue to see where we are. And we were able to get in, but it was in the false lumen.
Shoaib, in terms of time, let's say from the time we realized that she dissected or arrested
All right.
to the time you then got the wire in, what time are we, how much time went by?
So the whole, I can't say the whole procedure, like the whole procedure from screening time was around 33 minutes. So although the CPR was started quickly, but it did take a while to get in and to establish flow.
This looks like an Asahi wire, Shoaib, Asahi wire.
Yeah, so
That's rather than sand blue.
I think one is
Yeah.
cyan blue, and the other wire is actually a miracle wire.
Miracle, yeah.
So what we did was we took first cyan blue, and it was on a double lumen microcatheter, and in a hope that because what was happening was the wire was in false lumen, it was just extending the dissection, and as you can see by the now, we're almost in the mid LED, and we were still in the false lumen. So what we were trying was to get from the false lumen somehow back into the true lumen.
Puncture back.
The puncture back, and that's why they took the miracle wire and used the double lumen microcatheter, and that wasn't working either. So what we did was eventually desperation, not plan, because you can't plan for this. We took a small 2.5 ml balloon and burst it in the mid LED. So in the left screen, once we did that, there was disruption of the flow in the LED, and we could see just a little bit flow in the septals. You can see it there. And I think after that, we got some luck. And
so just a moment, let me interrupt you here, because I think it's important that the technique that you were trying to do with miracle was just to try to puncture back into the true lumen from false lumen. Have you tried, I mean, I'm sure you did, but to try another wire, just to find actually the true lumen right from the beginning? Because what happens, the CTO operators are very good in puncturing it back, but that's in the CTO condition. Usually when you have an acute dissection and a bit of hematoma, I find that trying to puncture back into the lumen is not that straightforward, not that easy. And trying to find the lumen before the dissection or right from the ostium of the left main might work.
So
yeah, I mean, it was a soft lesion, isn't it? So it could have punctured back, in the proximal segment. The other thought which was going in my mind was like having a stingray system, for example, if you're doing CTOs, that would have been quite useful there as well. Although,
but I think the problem here is that actually, if you look at the left main stem, it is ginormous. I don't want Shoaib to go back because otherwise the screen will crash again. But as soon as it's dissected, the left main is big. It's 6-7 millimeters, and actually the true dimension of the left main is probably about 3 or 4 millimeters. The rest of it is the false lumen, and the false lumen is going to be 3-4 times the size of the true lumen. And actually trying to wire there, I mean, it's near impossible, I think.
I think we didn't succeed actually with the miracle wire to cross back the after bursting the balloon and disrupting the dissection. It was the normal cyan blue wire or workhorse wire that got through. It wasn't the miracle wire, and the first, now thinking the good sign was that we could see the branch, we could see the wire going into the branches.
And presumably CPR is still ongoing here, is it?
Yeah, the Lucas device is on. Yes. So the surgeons actually came and said that before this that you had killed the patient and to stop doing the CPR. I think that was the turning point. Was by luck, I would say, where we were able to get into the distal left main, and then we stented back from it.
And can I just ask, was that a compliant or non-compliant balloon that you used, the 2.5?
Compliant.
Okay.
I think
Yeah, it's easy to rupture compliant balloon.
Yes,
Yes,
yes.
I was going to say you've got to have to go with a compliant, really.
Yeah.
It's a good trick to have in the back of your mind.
And I think after that we sort of back stented into the left main. I think the left main stent was 5 millimeter in diameter, and then it was post dilated. I think the largest balloon we had was 5.5, and we just dilated it as much as we could. And once we sort of back stented it, the left circumflex luckily opened up by itself.
You started stenting distally, isn't it?
Yeah, from distal to.
So you are molding the dissection along the wall distally.
Yeah. So we put like 338 into the sort of mid LED, and then a 526 back into the left main stem.
So you think in the left main you were in the false lumen, and rather than closing the circumflex, it actually opened. So probably at some stage you just tore the whole, let's say, the flap.
The flap, yeah.
I think what has happened is because they stented distal segment first, started stenting distally. So when they were coming proximally, they were molding the torn endothelium along the wall, to the wall. And when they came to the left main, they were because the wire was distally in the lumen. So they kept, following it back with the stents, and that's how the circumflex got spared, I think.
So do you want to go to your last slide, which is, I think, the most important, the learning points?
Sorry.
Next time, try not from mobile.
For mobile.
Computer, yeah.
We did try it before, it was working okay.
Okay, keep
we apologize for that.
Just go to the last slide in the interest of time.
Yeah. So the learning lessons are simple. I think the prevention is the best treatment. I think when the guides are not sitting in, there is no point in maneuvering them in. We should change them. The other point would be, you could easily argue there was some operator who did mention the point. He said you should always take a diagnostic catheter and before start of the angiogram, because that does show you what's the configuration, and you can then decide what sort of guide is going to best sit down. The main point, I mean, we got lucky there, but the main point was that he had the whole procedure was about 33 minutes. So when he was intubated and taken to CCU, we were not expecting that, whether he would have hypoxic back injury or not. But he walked out of the hospital with sort of minimal memory loss. So I think automated CPR is effective, and I think if we start it early, it does make a difference. And then it's basically persevering and trying, and that would eventually, with a bit of luck, will make the impossible possible.
Thanks for sharing this case.
I think there are 2 points. Can I quickly go through? There are two points. If the left main stem is very long, like in this case, it was unusually longer left main stem, or if it is very short, then the guide catheter engagement via the radial route can be quite unstable, because when the patient breathes in, it pulls out, the guide catheter keeps going in and out. To avoid that, I think, if you, as soon as the guide catheter engages, you have a guide wire ready to push it in any vessel like LAD or circumflex. When the guide wire is a bit deep, it stabilizes your guide catheter, and further maneuvering of the guide catheter can be easier. And you can use a second one. Let's say the lesion is in the LAD, guide catheter is pointing to the circ. So you can wire the circ even though you don't need it, but you can then you can pull back the guiding catheter and have a second wire with a bigger band to go to the LED. I mean, what I'm trying to say is a guide wire can help to stabilize the guiding catheter position, and you may not need aggressive maneuvering.
And secondly, Tariq bhai, occasionally when
Yeah.
the guide keeps shifting in and out of left main, you could use a guideline extension just to stabilize it.
Yeah, you can use it.
It's softer
But if
and
you
less
have one
traumatic.
guide wire, then you always have access to the lumen, and B, that it does move, does give you the stability, which which can be a problem because of the thoracic inlet with breathing in and out does cause significant movement of the guiding catheters via the radial route. So I usually have a guide wire ready to go in as soon as engage it, push the guide wire down.
Good learning,
Okay.
good learning
Well
case.
done.
Good learning case, and thanks for sharing.
Shoaib,
Can
very
you stop-
quickly, what's your main learning there? I think probably try and fit the guide appropriate to the vessel, isn't it?
Yeah, I think
yeah.
So
it's
one question.
Don't persist probably with a smaller guide. Just switch out earlier at an earlier stage.
It's I mean, in an elective, I mean, in emergency, you have an excuse. I think in an elective case, if you end up with a dissection like that, I think just because you didn't pick up the right guide, I think is the wrong thing to do.
Shab, you did extremely well, and the final outcome was, excellent, and really, a dying patient was saved. Excellent.
Yeah, if you can stop sharing.
I can.
His angina settled.
Yeah, the only other learning point I would say, probably going back to absolute basic, with one single NT channel on board, probably worth trying combination of two NT channels before embarking on intervention.
To be honest, I think right coronary was probably giving more angina. I think the culprit. LED, although I have not seen the initial shot, wasn't very good. So
wasn't that? Yeah, wasn't.
What's interesting is the ESC have updated their angina classification, haven't they? And they're now calling it chronic coronary syndrome. Yeah. And part of that on the pretest probability tables have also included dyspnea as a symptom to watch out for, which obviously this gentleman had. Now, whether that dyspnea was due to his angina or because of his COPD is difficult to work out, but I suspect he probably did have angina. I suspect if he'd pressure wired that LED, it probably would have been significant. So
yeah, it wasn't a bad idea to pressure wire. Yeah.
Right. We'll quickly move to Ahmed Shoaib, then third case. Is that okay, Sohail?
Yes, please go ahead.
Ahmed, sorry you've been waiting. I know we are overrunning. Ahmed, are you here?
Yes, Assalamu alaikum.
Okay, well,
can you hear me now?
Yes, we can hear you.
Assalamu alaikum, everyone. This is a case for calcified left brainstem and LAD and circumflex artery. It's 82 years old gentleman presented with anstomy, one of the DGH hospitals. ECG showed new onset atrial fibrillation with the troponin range of 3000 UNAs and two blood counts were normal. He did not have any significant comorbid conditions, independent in day-to-day activities, and echo showed good left ventricular systolic function, no significant valvular abnormality. I admit that I don't have diagnostic only angiogram images, but I can give you idea what's the report. It's a critical left brainstem disease. I will show you in the PCI pictures. Severe ostial disease in LAD and attached diagonal, severe proximal calcified disease in circumflex artery, and severe proximal to mid-vessel calcified disease in RCA. These are the pictures we took during the PCI. Despite having efforts, I could not get the angio. But there is no ambiguity, no need to IVUS, no need to OCT that this is critical left brainstem disease. Very clear. Another
Yes, I think we would buy that.
Yeah. Ahmed, assuming that we had the diagnostic shots.
Yeah. And this is now I need to say what's the plan, what the audience will say, how to manage this patient.
Having learned what we learned from the last case, yeah?
One quick question, Ahmed, while people are answering. Yes, this patient presented with an ACS. Before ACS, what was his symptomatic status? Was he getting angina and then developed ACS, or just an ACS?
No, he has history of crescendo angina.
Okay.
Also, Ahmed Bhai, what was the hemodynamic status of the patient on the table? Was the patient unstable or having ongoing chest pain?
Completely stable, no damping of the pressure, nothing.
We only got 50% votes. Can everybody else quickly vote, and we need to move on. Okay, there you go. This is what we got. 60% want to go to surgeons.
Average. Okay. That's fine. We agree with the majority. We refer this patient for MDT, actually cabbage, but the surgeons took this patient to MDT, and it was surgical turned down due to a couple of reasons. First is that the patient was exposed to COVID, and he did turn COVID positive, but exposed to COVID ward. And then the second thing is due to patient age. Despite the patient having no comorbidities, they advise complex PCI.
I think there is another. I think the distal LAD is diffusely diseased. And
yeah, distal LAD has diffuse disease, but we can see that.
Yeah.
This is the area where it's mid LAD actually. Technically, this is having severe disease, and then we can see the other images. The ostial LAD has disease, which is coming from the left mainstem.
Yeah, I mean, where the surgeon has to put a graft, I think that's quite a significant disease segment. So surgeon will not take this case. I know they will run away from this case.
Whilst before you move on, Ahmed, then I think it's a relevant point to bring a question for the poll, which is not relevant to this case, but in general. This is a question that should non-emergency left main cases be discussed in MDT prior to treatment, and this is non-emergency cases we're talking about. What would your practice be? I think somebody's clicked an option just for fun, and I can see why. So another 2-3 votes, then I'll close quickly. This should be straightforward. Okay, so this is what people think. Somebody think it's a waste of time, but majority say they should always be discussed. So the question is always, and then yes, but in some selected cases. So
if you ask the question, you can't not expect a response, I guess.
I know. that was Suhail, you clicked waste of time then. Anyway, we'll come to this at the end. Go ahead, Ahmed, carry on.
Okay. The next question is that what will be the PCI technique? If we call single stent provisional technique, we just do the LED left mainstem, or DK crush, or tap, or T stenting, or QLOT.
Show that angiogram again.
Yeah, I think we haven't seen enough.
Yeah, go back to angio while the post is up. This is assuming that we've decided to go for stenting. Well, it's a PCI session, so.
Show the caudal picture, please. AP caudal or PA caudal.
This is a P caudal.
Yeah, this good picture, yes.
I think we can see there's critical left mainstem disease and disease running into the ostium, certainly of the circumflex. And it looks like probably the LAD's involved as well. Yeah, so it's probably a true 1-1-1 bifurcation here, isn't it?
So you got 50% votes. If other people want to,
Can you put the poll again? Because I
it's
think
ongoing.
I can't see any. Okay.
I think you're sharing your screen, so I think you've come out of it. Sorry.
That's fine. That's fine.
Any more answers pending, or shall I stop it? Okay, I'll stop and share and see what people said. This is what people have said. So most people have gone for DK Crush.
I don't know.
They're well educated.
Some have gone for single
DK
provisional
Crush is
stent. Want to
very,
keep it
very,
simple.
it's a very sexy terminology, but honestly, I don't see many people use this one.
I mean,
It's
the thing
celebrate.
with bifurcation techniques is, so remember, bifurcations make up about 20% of your PCIs. Let's say you're doing 100 cases a year, for argument's sake. That means 20 of them will be bifurcations. If you then start chopping and changing between the various procedures, then you will only get a handful of each cases done with a particular bifurcation technique. So I think the answer is probably the one that you're most comfortable doing and do most often, because you never get good at something by doing less of it. You get good at something by doing more of it.
Yeah.
So if your two-stent technique is DK Crush, then you should do that. If it's Q-Lot, then you should probably do that. But if you're going with the data in left main stem, you would probably think about certainly doing a DK Crush, because the DK Crush 5 study showed it was better than provisional, and DK Crush 3 study showed it was better than Q-Lot stenting.
Yeah, I think the other thing obviously is left main is a different bifurcation compared to the distal bifurcations. And here you want, almost perfect result, because that's what will matter in terms of MACE and longer term outcome. And like you have said, DK Crush has evidence that it's a better technique compared to the other techniques, especially for the left main stem.
Go ahead, tell us what you did.
Okay, we start with the smallest balloon, not smallest, the relatively small mini tech with the dilatation, the left main stem, then LED, and we do the cutting balloon 3.5 in the LED left main stem. That went very easily, no problem at all.
Ahmed, these are standard workhorse wires?
Yeah, these are the standard ones. We don't need any other wires. We use cyan blue and cyan wire.
Good choice.
Things go smoothly.
And just remind me, you might have said this already, are you 7 French here or 6?
It's 7 French, 3.5
7
EBU.
French. Okay.
Yeah, 7 French guide. But here the dilemma starts. We unable to pass any balloons, fire or cross fire, one balloon or any microcatheter through the circumflex. We can see there is a sphere calcification. If you see my arrow there, this is not clear here, but in the previous images, and there is a bend. We unable to pass any balloon, any catheter down.
Just one question, sorry.
15, 20, yeah.
I mean, obviously the picture quality is quite poor here. After the balloon dilatation, was there any dissection in the LED at all?
No dissection.
Okay. No. Just because I was thinking to, either rotablating the circumflex if you are having
we
difficulty.
are planning to do, that's the thing is that we are planning to do rotablation, but we could not pass the microcatheter where we can pass the rotablation wire. That's the issue.
All right. Okay.
I guess the thing is, if you're going to rotablate the circumflex, you're going to have to pull out your LED wire. Were you concerned that the cutting balloon may cause some micro dissection in the LED or left main?
Yeah. At that time we did the ballooning. We were happy to take the rotablation wire, take LED wire out. There was no issue, but the main issue at this time is we're unable to pass any balloons, any microcatheter through circumflex artery. And at that time we were thinking what to do, either do the this is the next question actually. only do the PCI to left mainstem LED, which where some audience say that only do the provisional stenting for one artery, or laser, or something else.
Do you have laser available?
We have laser available, yeah.
Okay, then it gives you a, you know, an option if you have available.
Yeah, at that time, we asked some other consultant who is more expert in laser and asked for help, and then he is around, and we are preparing for laser actually. But still, we are not sure either laser can sort this tortuosity and band and calcification or not. We were not sure.
Well, if you use laser, laser is indicated in this sort of case, but actually it's moderate calcification on the label. So the question is, are you calling this moderate calcification or severe calcification? I guess what you need to try and work out is it angulation that's causing difficulty with
angulation was the issue.
Yeah, I'm just wondering what about passing a second wire down there and then trying.
We tried, we could not pass.
One thing you can do, maybe passing a rota wire directly sometime.
Try. I doubt that audience is agreed with that or not. To directly pass the rota wire there.
I mean, the problem with the rotor wire is it's 0.010 wire, and it comes with its own talker, and it's a talker that you're not used to using on a wire. So I have to say, I find it really difficult to try and maneuver that stainless steel wire. I mean, it can be done, I guess, and it's probably not. Yeah. It's probably worth considering and trying, but I suspect you probably will struggle.
I think what can be done, what I've done sometimes, embedding the microcatheter, such as turnpike spiral or turnpike gold, deep into the lean and then pushing the rota wire. It sometimes goes. The other option could have been using the door lumen catheter and taking the door lumen catheter on the south wire, and then then pushing the rota wire alongside through the second lumen, because that will give you enough support to push the wire distally. But the other here, the problem could be either there's a calcium spicule which has become worse after the balloon inflation, or it's an angle.
Okay, what did you get for the poll results out of interest?
Yeah, I think 40% said, let me bring it up again, sorry, one second, Ahmed. There we go. This is what people said. Can you see it?
Yes.
So not many answered, but the ones who did, 40-40, laser and something else. I wonder what that something else is.
I mean, I guess laser is only helpful if you have it available in your cath lab. There are many cath labs, unfortunately, which don't have laser.
Ahmed, could you put any balloon in at all, like the smallest one, or nothing went in?
We tried the 1 millimeter.
1.0, okay.
Yeah, it did not go.
Did not go.
So
and you think it's...
you know, if you take a bulkier balloon, like rather than smallest, you take a bulkier balloon, such as, maybe 2 or 2.5 even, push it, wedge it deep in the lean and inflate it. And sometimes it does it. It removes the calcium spicule. It gives you sometimes enough leeway to push the microcatheter. I've done that a few times. When nothing was going, microcatheter is not going, you take a balloon slightly bigger, like 2 millimeter, and then inflate in the after wedging it small part of the lean. And when you deflate it, you push it again, and you inflate, do 2 or 3 inflation, and sometimes the balloon might suddenly go. If balloon doesn't go, microcatheter quite often goes after that maneuver.
I used multiple times in this technique for pushing the microcatheter further, honestly. But here we didn't do it because it's after the 1 millimeter balloon, we started from the 2 millimeter, then 1.5, and then 1 millimeter. It was quite disappointing, actually.
Two quick questions from trainees which have come up. One is, but whilst doing this, was patient still hemodynamically stable? And the second one is, in these situations, is there any role of guideline extensions?
patient was that's I'm telling. Patient was stable. The blood pressure around 100 throughout the procedure, and there was no damping of the blood pressure. And patient was a little bit bored. The lengthy procedure was fine.
For guideliner, you have to take the LED wire out if you want to go into the circ with guideliner. And it creates the same sort of issue.
Tariq Bhai rightly pointed that we need to use the turnpike, and I agree with the laser. And honestly, when we use the turnpike catheter, it goes straight away. It takes 1 or 2 minutes and 1 minute probably, and then went straight away.
Right.
And I use first time turnpike catheter. This is really amazing. It's a 5-layer catheter, different structure, and I can share the video. Just a minute. Because the whole learning point in this case is this catheter. It's a simple catheter, not simple. It's a relatively difficult to use, but it's really changed the whole game. We don't need laser. We don't need anything.
Yeah, it has screwing action, so you keep on going.
Yeah, screwing action.
Yeah.
That's the make the difference.
They come in various types: turnpike spiral, turnpike gold.
Yeah, turnpike LP, third one.
LP. One question again: granuloplasty, bursting it at the mouth of the lesion with NC balloon. Asif Khan is asking. Would that be an option at any stage?
I mean, it is an option, but the problem is that if you cause a dissection, that then becomes a relative contraindication to rotablation.
Yeah, that probably won't be a good idea, I think.
I mean, I think that would probably be your last option if nothing else was working. But as we're being shown here, this microcatheter seems to be doing the trick.
But then I think you have to do ADR-like procedure if you're doing that balloonoplasty, like you mentioned.
No, because we've got the wire down the circ already, so it might be enough just to cause some small dissections at the proximal end, just to modify the lesion.
That's fine. Do you want to come out of this video now, Ahmed? Back to the case.
After that, it's easy to case. It's very easy case. We did that at rotablade, and we used 1.5 bar, and we pre-dilate the left circumflex artery with first 2.5 and then 3 and then 3.5 and Citrec balloon, and we use the culotte technique. We put one stent. It's a Megaton 3.5 by 32 stent at the 28 stents in the circumflex artery post dilatation with 4.5 balloon and then 3.5 balloon. Then put another stent in the LED and left mainstem. These are the balloons with different balloons used in the PCI to circumflex. This is the stent in the LED. But after putting the first stent, we noticed that there is a disease in the distal to this stent as well, and we put in another stent. First is Megaton 3.5 by 28. Another one is Ultimaster 3.5 by 12. I will show you the final result. This is the second stent we put in the LED.
So did you crash the circ stent or is it?
It was a culotte, I think.
Culotte, you did the culotte.
Culotte, yes,
Right.
culotte.
Okay.
And we did perform the final post dilatation in the use kissing balloons and then kissing 4.5 by 15 and 3.5 by 15.
Tariba, would you give any tips to the trainees when they're doing the kissing as to where the marker should be?
I think they should match, in my view, basically the proximal marker if we can. I think one important thing is never go high pressure with 2 balloons. I would slightly undersize the balloons, and because you are adding up in the where they're kissing in the left main. Because here you are actually trying to uh, reshape the geometry of the carina rather than getting the stand opposing the stand to the wall. So I think even a low pressure inflation, kissing inflation, will restore the geometry.
Take
And
home.
the advantage of doing sequential balloon dilatation before the kiss, or would you just go straight off with the kiss?
No, we did the sequential balloon dilatation. We did it with the 4 and 4.5, and then did the kiss, and then the final parts with the 5 balloon.
I think the LED was very well prepared. They had used cutting balloon, and of course, I think Leon was very well prepared. And it's got a beautiful result, I must say.
Did you use intravascular imaging at any stage in this case?
We used IVAS.
Okay, did you? Okay, that's fine.
I think that's the right sequence of what nicely he has demonstrated, and what Dr. Tariq also said, that if you have done sequential 1-to-1 at high pressure, then you don't need to go with the kissing balloon very high pressure. You have got your apposition with the sequential high pressure ballooning, and then with your kiss, you are just restoring the geometry. And then nicely, I think that's also a good point that he did in the left main with a circular balloon, because very limited data, but if you use one larger balloon rather than 2 balloons, you get better circularity of the vessel.
Very good case indeed.
A beautiful result.
Very quickly, Sohail, how many left main cases have you roughly done since being a consultant? Just rough idea.
Well, it's interesting. So there was some data that came out from China. I think Mamas has replicated this as well. That you need to do a certain number if you're doing them in a year to really get good results.
That's a question I'd like to ask the audience.
I think this is a very, very important question.
Because when we plan it, should anyone be doing it, or should we at least have a senior operator in the cath lab next door, or scrubbed with you? And how much is good enough,
I think personally, everyone should be able to do it because we are doing primary. And if you are challenged with left main stem in a primary situation and you haven't done that in real life, then you shouldn't be really participating in the primary PCI rota. Now, obviously, left main stem is the big spectrum. It can be very simple, or it can be very, very complex. And however, most of interventionists should be aware how to tackle the left main stem and its pitfalls attached with it.
So would you say for newer consultants, they should probably either get a friendly senior buddy along with these cases to start off with?
Yeah, I mean, if you have the facility, let's say, what happens if you're in middle of night, 1 a.m.?
Yeah, then you won't have anyone, obviously.
Yeah, you won't have anyone. But in general, I think elective, obviously, like this sort of complex case where you need rotablation or where you need DK crush techniques and IVAS and all sorts of things, it's always good idea to buddy up with a senior consultant and build up your own experience. But if you're challenged in the middle of the night, then you should be aware how to rescue the patient from that acute emergency. I wouldn't recommend rotablating in the middle of night or doing DK crush in the middle of night.
Yeah.
Obviously, your primary objective in the middle of night is how to save the patient and how to restore the flow, and we can do complicated procedure in the morning again when there is enough sport.
Agreed. Amber, do you want to stop sharing the slide? Excellent case.
Thank you very much.
If there is time, I have TAVI case where I did the jerkin, but if there is no time, then it's
I think we'll be probably
Yes.
running out of time today.
Yeah, okay.
But
We'll save that for next time.
Yeah, no problems.
I'm
I'm equally
checking.
happy.
Any questions from other trainees? You can unmute yourself now. We are almost at the end. By the way, one
I
more
just
question.
wanted
There you go.
to,
I've got one more question here. This is for the audience. Should intracoronary imaging be used routinely or only in some selected cases?
so while we polling, I'm just want to ask of my colleagues
Yeah.
about use of pot balloon size, because sometimes the distance between carina and depend how much distance you have left from bifurcation in the left main. Like in the smallest balloon length is 6 millimeter. So if you are using a pot balloon, which is 6 or 8 millimeter, you can still disrupt all the hard work of kissing balloon and carina by doing a pot. So I think it's important for trainees to leave a good distance, a balloon, a 6 to 8 millimeter before the bifurcation as well for doing a good pot.
That's a very good point, actually.
Yeah,
Leave enough space to pot, basically. Yeah.
it's an excellent point, obviously, but we have got shortest balloons available now. So that's.
What's the shortest you guys got in shell? Is it 4 or 6?
We've got 6 millimeter, 6 to 8, 6, 8, 12. Yeah.
I think you'd struggle to position anything less than a 6 millimeter balloon, to be honest. The other thing is, you've got to know your balloons because they expand in different ways. So depending on which post dilatation balloon you're using, you've got to know how it's going to expand in the vessel. So for example, the quantum NC balloon will poke out a little bit, and if you're too far distal when you're trying to do your pot, you will mess up the geometry of the carina.
So coming back to this poll, 2 people think it should be used in selective cases, but other people say it should routinely be used in intravascular imaging. The guy I trained with, he used to say you should use it all the time, even if you do it at the end, not necessarily at the start, but at least at some stage you should do it.
Yeah.
I
mean, I have to say I've never regretted using intravascular imaging. I've yet to do a case where I've regretted pulling out my OCT or IVUS catheter. And, there's good data. I mean, most of it is, of course, retrospective, but actually there's good data showing that if you use IVUS, particularly in left main stem stenting, that will actually allow you to optimize your results. And that optimal result will mean a better outcome for your patient.
Yeah, I think Suhail is spot on in this. I think there's another important point is there are different types of IVUS catheters. In the left main, the easiest catheter is the short tip one, sheathless eagle eye, which is 20 hearts. And when it's, there's lesser number of hearts, there is better penetration into bigger vessels. And so you could actually go in and out and see if the stent is well opposed or not, especially it takes much shorter time compared to the catheters with sheath. So I quite often use that, going in and out, seeing the left main is well opposed or not, because that's where you get the maximum benefit.
One last question, probably. The people still entering from the waiting room, they're just joining now. I think they got 1900 maybe wrong as 9 p.m. We're about to finish. But let's say in cases where you got, the cases which can go either way, stents or surgery, there's always going to be debate about what's the best evidence in the long term. Diabetic, let's say, diabetic with multivessel. And if they're not surgical turndowns, would you still persuade them to have stents? Because not many people would want to have their chest opened unnecessarily. But the surgeons will always argue that Lima is always better than the best.
I mean, the thing is, the surgeons get very worried that interventionists are just willy-nilly stenting left main stems. I mean, that's certainly not the case in our institution. We will, those which are not emergency left main stems in the middle of the night, we will discuss those at our MDT and have a formal discussion with the surgeons and come out with the best plan for the patient, because actually we're both working towards the betterment of the patient, aren't we? And this debate is still ongoing about whether the patient should have PCI or they should have coronary artery bypass surgery. I think the data in my mind is quite clear that if you're diabetic, you have left main stem disease, particularly distal left main stem disease, you are probably going to do better with coronary artery bypass surgery. And we have to be the advocate for the patient, and we have to put that case across and give those cases to the surgeons. Now, having said that, there will be patients who will come back, and I'm sure we've all seen it in our practice. They will come back to us and say, you know, I don't care what the data says, but I would prefer to have PCI. And I don't think that's unreasonable. I don't think it's unreasonable for the patient to meet with a surgeon and have the discussion and make a decision if they're stable and have the availability of time to have that discussion.
Yes.
You know, but you know, what we shouldn't be doing is, in my opinion, doing ad hoc left main PCI, because the problem is if it goes wrong, and there are, as you've seen, there are many potential pitfalls that can occur, then you know, people will start pointing fingers.
Another problem with ad hoc ones, which is not uncommon these days, is that I know that my lists are usually overbooked, and if anything complex, let's say left main bifurcation, where you want to have a proper time, you want to do imaging rather than two other patients waiting on afternoon list, I think it's better to bring them more electively rather than necessarily doing a complex procedure. And also, I mean, you have consented the patient for PCI, but you have not necessarily consented for a left main multi-vessel PCI. I would say that on occasions we have done just, let's say, relatively simple left main stem, not bifurcation and no other lesions, after consulting a buddy ache who is in the next room to say that patient is on the table and this looks like a provisional strategy or just an isolated left main stem lesion, for which the data is that it would be equivalent to cabbage. So I think occasionally, yes, but most of the cases I agree that it should be discussed in MDT and brought back, even if it's PCI, on a more elective and planned list.
Sarosh, you put a good question. Do you want to unmute yourself, Sarosh? Sarosh, can you hear me?
Sorry, I can hear you, but I'm just trying to put my 2.5 year old to bed.
Yeah, welcome. The question through, yeah.
My question was, how do you consent for left main elective PCI? So what risks do you quote?
Yeah, I think you know, there is a data from Excel trial and from the Noble trial that is fairly safe technique. I think the mortality risk, you know, if you are exaggerating, you can quote it as 1%. That's what we normally quote, 1% mortality risk in severe left main or complicated left main stem disease patients. But data is there, and I think MDT or heart team discussion is very important in elective patients, and most importantly, patients' own involvement, because there are some patients actually they will go for bypass when you tell them about the benefits, and they won't care about the wound. And there are a lot of patients actually who will not go for bypass. Doesn't matter how much you know, you tell them it's better. But from the procedure point of view, I think in this era, it's fairly safe. We have got almost equivalent outcome results in the Excel trial. So data supports you if you want to do the left main stem PCI. Of course, there are other factors, you know, your you know, the operator skill and patients' other comorbidities. Out of diabetes, Trail has already highlighted, bypass may be slightly better, but I think if you get a good result from PCI, then you know, it's not. I don't think it's inferior to bypass in the light of current trials data which we have, and with advance in stenting technology and anti-player, it's a fairly safe procedure.
In the shorter term, it's superior. In the
In
longer
shorter
term,
term.
it's inferior or equivalent. In the shorter term, it's superior.
But one thing off the record, which I want to say, is the quality of
The session is being recorded, Tariq Bhai. So.
Yeah, I'm sorry. Sorry. What I'm saying, I don't want to criticize my surgical colleagues. You know, in as the time is going on, we are getting honestly disappointing results from bypass. The patients are a lot of patients are presenting very early on, within 2-3 months even, with failed grafts, which is very disappointing. And then you just sulk that why did I let this patient go to surgeons? I could have got a better result in that case. So I think we have to keep all these factors in mind, but patient's own involvement is absolutely crucial. So we should put the facts and data in front of patients and let the patient pick and choose what the patient wants.
One other thing to specify to patients might be that if they are not surgical turndowns as such, then having a left main PCI does not mean they can't have surgery in future, just in case they need it.
Exactly.
As long as the distal vessels are good caliber vessels, they can still later on have surgery when it's relevant.
Yeah.
What I'll do I'll stop recording now. Is that okay? And get everyone to be more casual then.
Yes.
Okay.